mixed in almost all eyes presenting with PCV, and hyperreflective material was more in type 2 and mixed CNVMs. Fibrin was more on fundus photography. The poorer baseline visual acuity was seen more with hyperreflective material patients, and ELM intactness remained the most consistent variable. So eyes with no HRM at month 12 had best mean visual acuity. Those with undefined HRM had the worst mean visual acuity. So these are the typical changes that are seen on OCTA. Initial presentation with before injection and 4 weeks follow-up. This is how it responds over a period of time on OCTA. Decrease in the size of neovascular membrane. So another example showing the area of the membrane vessel area. It's a case 2 showing the decrease in the membrane again. So there was an article which showed presence of different types of lesion on the in the same patient at the same point of time. A classic lesion that is seen here, and a knuckle lesion that is seen here. So a deep learning. So coming to IPCV, multimodal imaging, we can see a speckled hyperfluorescence in FFA and BVN as well as those polyps which correspond to the hyperreflective material under the PEDs. So polyps and ICG can be a whole-like pattern or a cluster-like pattern, and we know that the polyps can be divided into peripapillary, extramacular, and macular. So this is a case again by Usha Chakravarti et al. So we can see some fibrin collection here and lots of hard exudates. So over a period of time after injections, the hyperreflective material persisted below the retina as well as the sub-RPE, and ultimately there was an eventual scarring with a very poor improvement in vision. So image showing FA as well as ICG. FA, as we know that it doesn't show clear cut leakage, it can show some occult leakage in a PCV, but whereas in an ICG it can show BVN as well as a polyps. So this is a 6 mm OCTA scan, which shows a rough image of a vasculature, but a 3 mm clearly shows a demarcated BVN there. Polyps are sometimes difficult to visualize on OCTA. So this is a double layer sign. I think it will be covered later. OCTA again in PCV, this was a case we keep presenting. So a nice good delineated BVN. In fact, this entire thing is a BVN. So we can see the bunch of the BVN here with the polyps at the end, which correspond to this area. So coming to unfast visualization on OCTA, it can give an extent of the lesion, but it's really difficult to predict where the piece, the polyp is. When it's associated with the polyp elevated area, we can get to see the elevation here as seen on OCTA as well as the unfast section. So unfast OCT, again, it can delineate the geographical extent of the PED, like different layers of RPE detachment, outer retina as well as the Brooks. So this gets obvious even at the outer retina. Once we go down below the outer retina, it gets more prominent. But sometimes if the PED is limited, the multiple PEDs, we can get to see the extent of the PEDs. So polyps on FAF, it was noted that they have a hyperfluorescent halo with a hypoautofluorescent center. Post PDT, it was noted that when the polyps disappear on an ICG, even the polyps on FAF, they kind of lose the hyperautofluorescent periphery. So these are the notch thumb-like sign and string of pearls appearance on OCT-B scan. So this was a case wherein we had done a PDT. This was before PDT. It was a recurrent polyp, so with a BVN. So this was a BVN that was noted on a color image of OCTA. So post PDT, we can see the regression of the fine vasculature, and this is a large coarse vasculature that is seen post PDT. Coming to chronic CSCR, the classic signs on B scan, OCT B scan, the thickened choroid, thinning of the inner choroid, RPE, hypertrophy, atrophy, subretinal fibrin, dipping of the posterior retina, subretinal hyperreflective dots, elongated photoreceptors, intraretinal hyperreflective deposits, outer retinal changes, and SR fibrosis. These are SD-OCT features. You can see thickened choroid here under the active CSCR. So long-standing CSCR, wherein we can see the dipping of the inner retinal layers. So it's a subretinal fibrin there. and resolved CSCR, but with a thick choroid. This is another eye, so other eye of the same patient. So this is an active CSCR, and when the middle and outer choroidal vessels they enlarge, they can push the inner retina, inner choroid, so to form a membrane-like structure there. So OCTA features of CSCR, we have done a study seeing the FFA and FAF as well as OCTA features. So when we look at OCTA, obviously the inner retinal layers don't show anything, but when it comes to outer retina, it can show a rough extent of the involvement of choroid. So these are the images showing FAF, OCTA, and ICG. So there was a good correlation between the ICG as well as OCTA. We had done image J imaging modality based on this. So the results were both OCTA and ICG corresponded well to the extent of involvement of the choroid in chronic CSCRs. Coming to autofluorescence, in chronic CSCRs, they can present in different ways: granular hypoautofluorescence, the macula, age, elderly age, confluent hypoautofluorescence, and descending tracts. These are all independent variables which determine the visual acuity and prognosis. So, but confluent or hypoautofluorescence at the macula, like large areas of dark areas, they do indicate that large areas of atrophy, which are consequent to chronic CSCR. So, case example, this one example is a 62-year-old gentleman who had a CSCR-like picture, but when we look at the RP here with an intact RP, there is hyperreflective echoes below the RP. So, when we did a OCTA, we could find the CNVM complex there, and it decreased post-injection. So this is pre-injection and this is post-injection. So to conclude, color fundus photos were the old method of disease classification and monitoring. It had its own limitations, like the clarity of the photos and the proper documentation and other things. So, but multimodal imaging, it adds to the qualitative and quantitative assessment, and it provides in-depth understanding of the disease pathology with the complementary and confirmatory information, and it really helps in follow-up and prognosis. Thank you.
I would request Dr. Mahesh P. Shanmugam to hand over a memento to Dr. Santosh Gopikrishna. Thank you, sir.
So we'll have questions at the end, or
At the end of the session.
End of the session we'll have the questions. Okay. I request everybody to please note down the questions so that at the end of all the talks we can discuss.
I would call upon Dr. N.S. Muralidhar to talk on ICG for the diagnosis of AMD, IPCV, and CSCR. Dr. N.S. Muralidhar is currently the head of Retina Institute of Karnataka. He did his graduation from Bangalore Medical College and post-graduation from the renowned Dr. R.P. Center AIMS with a gold medal. He did his VR fellowship from Sydney Eye Hospital, Australia. And he established the Retina Institute of Karnataka in the year 1996. Dr. Muralidhar has been awarded Rustam Ramji Award by the AP State Ophthalmic Society in the year 2000 and Dr. Ravi Kumar Reddy Oration from Sarojini Devi Eye Hospital in the year 2005. He's presented many papers in state, national and international conferences. His special interests are diabetic retinopathy and idiopathic macular telangiectasia. Apart from ophthalmology, Dr. Muralidhar pursues a great passion in music.
Thank you. Thanks to the Netra team for inviting me to be part of this very good symposium, which is not talked about that often in all our meetings. So thanks for organizing this meeting. I'm going to talk about ICG angiography. ICG angiography has been there for more than 25 years, 30 years now. And the chief difference between ICG and fluorescein is that the excitation and emission spectrum of ICG is in the infrared range, the excitation being at 800 nanometers and the emission being at 830 nanometers. And because of this particular property, we are able to use ICG to visualize structures which are beneath the retinal pigment epithelium. Our traditional fluorescein angiography does not allow us to study the choroidal circulation well, because the retinal pigment epithelium blocks the choroidal circulation details, and this is where the ICG angiography comes into play. And currently there are 3 types of fluorescein ICG angiography machines available. One is based on all of them are based on digital camera. This is based on a regular infrared light and reflection. This is that other 2 are based on scanning laser ophthalmoscope and confocal scanning laser ophthalmoscope, which uses the laser beam instead of regular beam, and there is a confocality which gives much more definition of the structures in a particular focal plane. We use the Heidelberg Retina Angiogram 2 HRA2 system, which has been working for almost 2 decades now very well to give us various informations about the various structures, and it uses a diode laser illumination system with an output of 805 nanometers. The technique is very similar to fluorescein. We use 25 milligram of ICG dissolved in 5 ml of the solvent, and final concentration we obtain is 5 to 9.5% of sodium iodine. It is drawn through a millipore filter, as you see here, injected before or after sodium fluorescein. In our institute, we often combine fluorescein and ICG angiography because our machine is able to do a simultaneous FFA and ICG. Otherwise, you could do ICG and FFA alone at different times using the same machine. This is one of the very good pictures that we can get with ICG angiography taken with a Storinghi lens. Storinghi lens is a lens that is placed on the cornea and used with the HRA machine. You can almost get entire 180-degree view of the fundus. And notice that the entire choroidal system and the retinal vascular system is so nicely delineated. So no wonder that in 90s, when the ICG angiography was kind of got a resurgence with the advent of digital angiography systems with the work of Hayashi and Yanuzzi. Everybody thought that we're going to solve many mysteries of retinochoroidal diseases. We're going to have new inputs into the way we understand the diseases and treat these diseases. So in 1990, when I came back and started my retinal practice, our treatment of AMD was mainly limited to finding out whether it is extrafoveal, juxtafoveal or subfoveal, and finding out whether it's a classic or an occult type of neovascular membrane, and we had only laser to treat these kind of AMDs. Especially when we were studying occult CNVMs for which there was no treatment, ICG was being used a lot to study them in more detail. So based on the ICG characteristics of occult CNVM, we developed many treatment modalities like ICG guided TTT, ICG enhanced TTT, ICG guided photothrombosis, and feeder vessel occlusion. All these techniques were tried in the 90s, because there was no other treatment available for age-related macular degeneration. Once in the last 1.5 decades, the anti-VEGF therapy has changed the scene completely, because anti-VEGF therapy made superfluous the type of CNVM, whether it was a juxtafoveal or a subfoveal or extrafoveal CN, whether it is a classic or occult, it didn't matter. The treatment remained the same, and therefore the use of ICG came down drastically, and we started treating all the patients with anti-VEGF therapy. But slowly in the last decade or so, we have realized that there is a need for ICG in our regular practice. Why? Because there are certain group of patients who are non-responders to anti-VEGF therapy, and most of them are the entities called PCV or RAP, and we are becoming aware that many patients whom we treat as age-related macular degeneration actually have some of these subtypes like polypoidal choroidal vasculopathy or retinal angiomatosis proliferans. And to diagnose these diseases, today ICG is become the modality of choice, and to manage also occasional case of an atypical CSR, and in studying inflammations, ICG is now useful. Just talking about few of these entities, polypoidal choroidal vasculopathy, you all know, is an entity which presents with multiple recurrent xerosanguinous retinal pigment epithelial detachments. Anatomically, it is characterized by branching blood vessels and polyps seen. These are actually under the retinal pigment epithelium, and therefore fluorescein angiography does not allow you to visualize them as branching network and polyps. It just shows a mottled hyperfluorescence, which increases in the late phases. But having said that, I must congratulate Dr. Yanuzzi, because it was not with ICG that he proposed the the classification and the system of idiopathic polypoidal choroidal vascularity. It was based on fluorescein angiography and his astute observation. He wrote his classic paper on IPCV. On ICG, PCV is defined by the presence of single or multiple focal nodular areas of hyperfluorescence arising from the choroidal circulation within the first 6 minutes after the injection of ICG dye with an associated branching vascular network. This is the definition given by the International Study Group for PCV, and here you can see the branching vascular network and the polyps that are delineated on ICG angiography. You will never be able to see this detail on your fluorescein angiography, and this is a lady. It's a typical presentation of a pigment epithelial detachment, 70-year-old lady. You have some exudates here, and ICG angiography clearly delineates the network of blood vessels and polyps that are seen in the juxtapapillary region. The most two common locations for polyps are either juxtapapillary or around the fovea in the posterior pole, either in the juxta or the subfoveal region. Sometimes the PEDs may not be there and there could be exudative reaction. And this is a case of severe exudation next to the disc in this lady, and then we saw the OCT was suggestive of a PCV, and here we see the network of polyps along with a bunch of polyps along with the network of blood vessels next to the disc, and this is an unusual exudative variety of PCV that we often come across. So today, for diagnosis of PCV, ICG is the gold standard, and even for follow-up to see whether the polyps have regressed, whether they are active, whether they are recurrence, ICG is the gold standard. I don't think OCT angiography has yet replaced ICG as a tool for studying PCV as of now. Maybe with advancements in our imaging technologies, OCT angiography may prove to be better than ICG. But as of today, ICG still is that modality of choice to study PCV, diagnose, study and follow up patients with polypoidal vascular choroidopathy. Few words about RAP. RAP is a type of CNVM. Clinically, we see hemorrhages and lipid exudates in the area of occult CNVM. Why we are interested in RAP is because they often show poor response to anti-VEGF, and ICG can establish the diagnosis. This a 75-year-old man presented with a lesion here with hemorrhages and exudates. This was the OCT picture of the lesion, and this was the fluorescein angiogram, shows intense hyperfluorescence. Initially, he was treated with anti-VEGF therapy. There was no response. This was the lesion, same after 2 injections of anti-VEGF, and the ICG angiography shows hyperfluorescence of the lesion. Notice that intense hyperfluorescence, what you see in the midst of this hyperfluorescent lesion, and this we feel represents a RAP. Coming back to AMD. Does ICG help in AMD at all? This is a patient who had right eye serous detachment with some exudation, some hemorrhages, and the fluorescein showed a kind of a ill-defined lesion here, leaking. We gave him Avastin. This was the OCT picture. We gave him Avastin, and patient after few injections of Avastin, no change at all, although the vision remained reasonably good. And ICG angiography, we thought, okay, this is a case of PCV, but even here we have found a surprise that this is only a plaque. There was no PCV lesion at all. So we continued the anti-VEGF therapy after 11 injections of Avastin because patient could not afford any other type of anti-VEGF therapy. We finally got some response in this patient. So in patients with AMD, even though you are not able to see PCV, even absence of a PCV or a RAP could be a helpful tool for you to manage these patients as a patient of AMD. It shows much more wider hyperfluorescence. You can see that the hyperfluorescence is much more widespread than what you had seen on fluorescein angiography here. So it shows much more widespread pathology, although I have never understood how exactly it helps us to manage these patients in a better way. Again, showing that the FFA shows only focal hyperfluorescence, but a lot more areas of hyperfluorescence are seen on ICG or in a case of CSR. Having said that, do we use ICG in CSR a lot? No, I don't think we do. This is again example of hyperfluorescence seen on FFA, and this is actually, we have taken this ICG from a Zeiss ICG camera, and you can see the difference in the characteristics of the ICG angiography in a confocal laser-based system compared to the regular digital camera system. The definition of blood vessels is definitely not as much as you would get in a Heidelberg or a confocal laser-based system. Today, do we use ICG and CSR? Of course, one, to rule out PCV or NAMD, because these two could be confusing. Even patients with PCV can present with serous detachment. And occasional patient where there is a chronic CSR, you don't know what to do, maybe you want to offer a PDT to these patients, then when their FFA does not show a definite leak, it shows multiple areas which are not really typical, you don't know which to treat. ICG could be used to see which areas are leaking, and you give PDT treatment to these areas. So in conclusion, ICG role in AMD has diminished. You know, what was used a lot in the past has now diminished definitely. But today we realize that a large number of our patients are not AMD, they are PCV, and to diagnose this subgroup of patients, managing them better. Thank you very much.
I request Dr. Indu Singh to present a memento to Dr. Muralidhar. I call upon Dr. Venkatesh Kadri to speak on OCT biomarkers for AMD, IPCV and CSCR. Dr. Venkatesh Kadri is currently working as a retinal surgeon at Netradama Super Speciality Eye Hospital. He did his VR fellowship from Shankar Nethralaya, Chennai. He has several publications in national and international journals and invited faculty and speaker in various national meetings. He is awarded Dr. Mangaya Sharma Award for the best outgoing student in Masters by the AP University, and his area of interest is multimodal imaging and challenging retinal surgeries. Over to you, sir.
Good morning, everybody. At the outset, I'd like to thank Dr. Bhargav and Netra team for giving me the opportunity to present here today on this very focused topic on macular diseases and PDT. There are several evolving concepts, and then it's important that all of us learn how things are changing with all these diseases. So if there's one investigation without which the retina OPD never runs, it is OCT. Without OCT, I don't think we can run our practice as of today. So with that background, let's just go through briefly these three very large conditions, try to do justice to each one of them. So AMD broadly is classified into non-neovascular as well as neovascular. And if you look at drusen, the recent description of drusen is that based on internal refractivity, these are highly magnified images, so they're slightly blurred. So you can have hyporeflective or low reflective drusen, you can have medium reflective, or you can have high reflective drusen. Apart from that, you also have a core on the drusen. This is also something new. You can have a hyporeflective core which is inside the drusen, and you can have a speck overlying that sometimes. Or the core itself can be hyperreflective. Or sometimes you can have the hyperreflective core without anything else, and it is homogeneous. So there are various studies nowadays showing us that drusen are dynamic structures, and then they go through these repeated cycles of increase and decrease in volume. And then they seem to grow in a cubic pattern, and they keep increasing and decreasing. But the important thing over here is that the regression occurs pretty fast. Pigmentary changes also, all of us know, are seen on color fundus photographs, and they also suggest disease progression. This is a particular article which is just talking about one small finding, and this you see these large PEDs as well as drusen here. There is this small speck which is seen above the PED, and it's a follow-up over 2 years, and they have noted that there is migration as well as proliferation of these hyperreflective spots, and they have noted that it corresponds to the pigmentary areas which you're seeing in the fundus. So the drusen cores as well as reflectivity, why is it important? Because they can be associated with areas of focal RP atrophy. And higher baseline drusen volume has also got increased risk of either a choroidal neovascular membrane or a geographic atrophy. Focal loss of overlying photoreceptor layers sometimes will also be shown to be corresponding with the drusen height if you measure the drusen height. There's another entity called as reticular pseudodrusen. Now this was first described in 1990 as a peculiar yellow pattern in the fundus when you're looking at the fundus, and you don't think that is exactly a drusen. And you can see these structures better when you're using blue light. Pseudodrusen seen by SD-OCT corresponded to the subretinal drusenoid deposits, which I'm going to show you. So this is one thing which has been described nowadays, that there is a stage in this reticular pseudodrusen, which it goes through normal stage 1, 2, 3. These 3 white lines are the ones which are seeing normally in the OCT. The outer, what is this? I think the battery is low. So there are 3 hyperreflective lines which all of us see routinely in OCT. Those are the 3, I think I'll just wait for that band to go away. Sorry, sir? Just close, okay. Yes. So these 3, yeah. So the outermost is the retinal pigment epithelium, the innermost is the ISOS junction, and the one in between is the interdigitation zone, which is between the outer segment tip as well as the apices of this retinal pigment epithelium. So in stage 1, you get the granular appearance of these 3 lines, and it looks fairly okay. Most of them, they are asymptomatic. In stage 2, there is elevation of this ISOS as well as this interdigitation zone, as you can see on the OCT over here. And in stage 3, there is disruption of this ISOS, and the subretinal deposits goes through that. That is when it is significant. A few more terminologies which have been described. Like over here, you are seeing this outer retinal tubulation, which is also associated with this area of geographic atrophy. Then dome-shaped RP elevation on the junction of the geographic atrophy. I want to put that. Okay, thank you. Then irregular RP elevations and the basement membrane. These are some of the terminologies which they are describing nowadays with AMD. And sometimes you get this crown-like elevations with debris. What is important to note is this area. This is the area of the geographic atrophy within which they are describing these entities. Then sometimes you can have splitting of the RP as well as basement membrane complex. So that was in brief about the non-neovascular variety of AMD. Now moving to neovascular AMD, what we all know till now is type 1 or fibroscular PVD or occult CNV. Why is it called as occult? Because it's beneath the retinal pigment epithelium, as it is noted over here. The whole complex is below that. If it goes above the retinal pigment epithelium, it becomes type 2 or classic CNV. The third variety is RAP lesion or retinal angiomatous proliferation. Over here, it has got 3 stages. Stage 1 is when the pathology is intraretinal. The neovascular tissue is only intraretinal. If it goes subretinal, like you can see in this case, with also a PED, but the RP is not breached. If the RP is not breached, then it is stage 2 of RAP. Stage 3 is when it goes under the choroid and then it becomes choroidal. As you can see over here, the RB is breached. These are just some guidelines about the OCT in RAP lesion. Now, the new term which all of us have been hearing since the last 2 years is pachychoroid, which helps us understand this entire spectrum of conditions. So just to brush through the basics, how is the anatomy of the choroid, which is important to us? You have the suprachoroidal lamina, which is from the sclera to retina, which I'm talking about, from outside to inside. You got the hallux layer, then the sattler's layer, choriocapillary, as well as the Bruch's membrane, and then the RPE. 4 conditions have been described: pachychoroid pigment epitheliopathy. Here it's by and large just granular appearance on the fundus, and you don't really have any symptom in the patient. Next is central serous chorioretinopathy, which we are all aware of. Then you have pachychoroid neovasculopathy, which is similar to type 1 or occult CNV, like I just showed you before this. The fourth one is the big entity, which is polypoidal choroidal vasculopathy. So just a few points on pachychoroid. Basically, the choroid is more than 300 microns, and they are shown to cause this choroidal hyperpermeability. And you can have Sattler's layers usually attenuated at the site of the polyps. We will just go through some important things. One is the thickening. Second thing is pathologically dilated veins in the hallux, like I told you, and thinning in the Sattler's and choriocapillary, which is above that. I'll show you some images. So this is just a timeline as to how it has evolved over time. In 1955, you have the first FFA. Then in 86, you have the ICG. 1991, we got our time domain OCT. Spectral domain OCT came in 2008. 2013, we got the Swepsos OCT, and now we're talking about pachychoroid, which helps us understand all this. Now, this is an important slide which is showing us 2 different patterns which is happening in AMD. If you have the normal drusen and then it is going into geographic atrophy, we are looking at the VEGF pathway. If you're looking at the pachychoroid pathway, then it is pigment epitheliopathy, you have CSR, and then it goes into the PCV, which is a more severe form of AMD. So just a few slides on PCV. So PCV has got certain diagnostic guidelines, which I'll not go into the details. You have definite PCV as well as probable PCV for diagnosis. Everest criteria also has criteria for diagnosis like focal hypofluorescent lesion before 6 minutes on the ICGA, and one of the following like BVN, pulsatile, several points there in it. Now, a PED is something which is important to note in a PCV. So you can have these typical notch-shaped or notched PEDs, which are the site of the PCV, and you get this typical thumb-like elevation of the PED in PCV. So the typical double layer sign, which you can see in this picture. So what is this double layer sign? Double layer sign is when you have the retinal pigment epithelium above, like in this case, and the line below is probably the Bruch's membrane, and you have hyperreflective area in between. So that becomes a double layer sign, which is seen both in PCV as well as CSR. And this is your typical thumb-like elevated PEDs, which also has a wall around it. Focal choroidal excavation, a big entity which are being described in a lot of conditions now, where this dipping of the RPE you will notice over here, corresponding to that area on the ICG. The next one is en face OCT. En face OCT is when you see the lesion end on, you find this cluster of polyps as well as the BAVN which is associated with that. And this one particular article has described this appearance as a Bola sign, where you see this polyps and the BVN which are attached to each other. Few slides on central serous chorioretinopathy. Probably this is one of those diseases where we don't understand much. The OCT important areas we are looking at is choroid, RPE, subretinal space, as well as neurosensory retina. So I'll just go through some pictures. This is a classical acute central serous with the subretinal fluid and a PED. But look at the choroid, it is 561 microns, it's thickened. But you look at this patient, again acute central serous, but then the choroid is having normal thickness. So the EDI OCT has helped us see more things than what we used to see earlier. In this zone which is over here, we are able to see mild photo outer receptor segments atrophy, like what Dr. Santosh also was talking about the CORA. So the mild photo outer receptor atrophy is visually quite significant, which is seen more in chronic CSRs. Now again, the double layer sign, like what we're talking about, is also seen in central serous over here, these two layers under the subretinal fluid. So this picture is showing us dilated hallus layers on the outside or towards the sclera, and what you see here is compression of the choriocarpi. So this compression is very important when you're looking at either PCV or CSR. Oh, I think it's completely on. So I think attach again. Or shall I get my laptop? ಇದರಲ್ಲೇ ಹಾಕ್ಬಿಡ್ತೀರಾ? Hold it. Yeah. Okay, let's see.
In the time it's being used to set up, are there any questions to the previous speakers? An interesting session. No questions? Sure. I have a question to Dr. Santosh. So, like a lot of new words, new technology. So what would you really use in your routine practice? Like, so I would say a color photograph and OCT, maybe OCTA, FFA, ICG. But then a lot of other things like color, different colors, like this lifetime fluorescence and things like that. What would you really use and what is the relevance at the end of it?
I feel it comes down to the routine fundus photography, FF and FFA and ICG and basically OCT. So I would, if I see a CNVM or even a dry AMD, the first thing I'll get a fundus photo and a OCT and maybe FF along with that. FF maybe in the long term for the progression part of it. But if I feel there's an activity, since OCTA is also there, if I have a suspicion of a CNVM lurking underneath, then I might ask for a OCTA also. So that will give me a clue kind of how to go about, because large drucenoid PDs sometimes they do harbor a CNVM underneath. But, you know, like we don't.
So you wouldn't routinely do an octa when you do an OCT?
Octa we are getting it done, sir. I mean, even early we are not usually getting it done. Intermediate AMD and advanced AMD I'm getting it almost for all the
adapters.
Are there any?
I think these new technologies, if you continue to use them and get used to, spend time at them, then only you are able to understand, especially OCTA. You really have to understand the machine and sit in front of it. It's very easy for a technician to do this OCTA of all these kind of retinal diseases, but till you look at all those sections yourself and then move the segments and move it up and down to have a look at the OCT line.
That's a problem.
Line scan and then compare.
Yeah, there's nothing like a printout of like a OCT-B scan.
Absolutely. The printout of line scan thing has gone now. I think it's okay, so we can continue with the presentation.
Sorry for that technology glitch. So I think all of us also need to do an additional course in, gadgets and biomedical engineering and all that. Otherwise, you'll be stuck. So this is where we were. We were talking about OCT and CSR. So CSR is showing us this dilated hallux vessels and compression. So the compression is simple changes within the vessel wall, usually seen in chronic CSR. And after 2 months of the same patient, another finding which you note over here is hyperreflective dots, which is magnified over here. After 2 months, this hyperreflective dots have come down, even the SRF has come down. So that's another marker for us to note in case of chronic CSR patients. This is one rare case which they have described where you have a high pressure PED which has ruptured. It has not only ruptured the retinal pigment epithelium, but it's also gone through the retina and then it's gone into the vitreous with a full thickness retinal break. So this is one important slide which is showing one important marker in chronic central serous. If you notice this area which is under the neurosensory retina,
within the vessel wall,
this is
usually seen in
progressive
chronic CSR.
elongation of the
And
photoreceptor outer segment.
after
If you
2
notice
months
this
of the
area
same patient,
to this place and then
another
here,
finding which you
definitely
note
the
over
area
here
has
is
become much
hyperreflective
longer.
dots, which is
Longer
magnified
doesn't mean
over
it's
here.
doing well, it
After 2
means it's
months,
getting
this
worse.
hyperreflective
And
dots
over a
have
period
come
of
down,
time,
even the
you'll
SRF
find that
has
this outer
come
segment
down.
is
So
this
that's
one.
another marker for us to note in case
So in
of chronic
conclusion, what I'd like to say is because we have multimodal
CSR patients.
imaging and we have
This
so
is
many
one rare
various
case which
technologies
they have
to
described
see,
where
the best
you
thing
have
is to put all these images together,
high pressure
FFA,
PED which has
ICG,
ruptured.
OCT,
It has not only
and
ruptured the retinal
autofluorescence
pigment
and everything
epithelium,
together.
but
Only
it's
then it
also
will
gone
make
through the retina
sense
and
to
then
us
it's gone
to
into the
analyze
vitreous
the
with the
patient
full
and decide
thickness
on patient
retinal
management.
break.
So I wanted to put up this quote after
This is one important
going through
issue.
this place and then
Another
here,
finding which you
definitely
notice
that area
here
has
is
become much
hyperreflective
longer.
dots, which is
Longer doesn't
magnified
mean
over
it's
here.
doing well, it
After
means
2 months,
it's
this
getting worse.
hyperreflective
And
dots
over a
have
period
come
of
down,
time,
even the
you'll
SRF
find that
has
this outer
come
segment
down.
is
So
this
that's
one.
another marker for us to note in case
So in
of chronic
conclusion, what I'd like to say is because we have multimodal
CSR patients.
imaging and we have
This
so
is
many
one rare
various
case which they
technologies
have
to see,
described
the
where
best
you
thing
have
is to put all these images
Upon
together,
high pressure
the
PED which has
top and
ICG,
posterior
OCT,
for
It has not only
AD
ruptured the retinal
autofluorescence
pigment
and everything
epithelium,
together.
but
Only
it's
then
also
it will
gone
make
through the retina
sense
and
to
then
us
it's gone
to
into the
analyze the
vitreous with
patient
full
and decide
thickness
on patient
retinal
management.
break.
So I wanted to put up this quote
So
after
this is one important
going through
slide
the
which is showing
diseases.
one
The
important
art of
marker
medicine
in chronic
consists of amusing the
central serous.
patient
If you
while
notice
nature
this area
cures the
which is
disease.
under the
This is what
neurosensory
it is.
retina within the vessel
So
wall,
this is
usually seen in
progressive
chronic CSR.
elongation of the
And
photoreceptor outer segment.
after
If
2
you
months
notice
of
this
the
area
same
to
patient,
this place and then
another
here,
finding which you
definitely that
notice
area
here
has
is
become much
hyperreflective
longer.
dots, which is
Longer doesn't
magnified
mean
over
it's
here.
doing well, it
After 2
means it's
months,
getting
this
worse.
hyperreflective
And
dots
over a
have
period
come
of
down,
time,
even the
you'll
SRF
find that
has
this outer
come
segment
down.
is
So
this
that's
one.
another marker for us to note in
So
case
in
of chronic
conclusion, what I'd like to say is because we have multimodal
CSR patients.
imaging and we have
This
so
is
many
one rare
various
case which they
technologies
have
to see,
described
the
where
best
you
thing
have
is to put all these images
Upon the
together,
high pressure
FFA,
PED
the
which
top
has
and
ICG,
ruptured.
OCT,
It has not only
and
ruptured the retinal
autofluorescence
pigment
and everything
epithelium,
together.
but
Only
it's
then
also
it will
gone
make
through the retina
sense
and
to
then
us
it's gone
to
into the
analyze
vitreous
the
with the
patient
full
and decide
thickness
on patient
retinal
management.
break.
So I wanted to put up this quote
So
after
this is one
going
important
through
slide
the
which is showing
diseases.
one
The
important
art of
marker
medicine
in chronic
consists of amusing the
central serous.
patient
If you
while
notice
nature
this area
cures the
which is
disease.
under the
This is what
neurosensory
it is.
retina within the vessel
So
wall,
this is
usually seen in
progressive
chronic
elongation
CSR.
of the
And
photoreceptor outer segment.
after
If you
2 months
notice
of
this
the
area
same patient,
to this place and then
another
here,
finding which you
definitely
notice
that
here is
area has become much
hyperreflective
longer.
dots, which is
Longer doesn't
magnified
mean
over
it's
here.
doing well, it
After
means
2 months,
it's getting
this
worse.
hyperreflective
And
dots
over a
have
period
come
of
down,
time,
even the
you'll
SRF
find that
has
this outer
come
segment
down.
is
So that's another
seeing the euphoria
marker for us to note in
So
case
in
of chronic
conclusion, what I'd like to say is because we have multimodal
patient.
imaging and we have
This
so
is
many
one rare case which
technologies
they
to
have
see,
described
the
where
best thing
you
is
have
to put all these images
high
together,
pressure PED which has ICG, OCT. It has not only ruptured the retinal pigment epithelium, but
only
it's
then it
also
will
gone
make
through the retina
sense
and
to
then
us
it's
to
gone into the
analyze the
vitreous
patient
with
and
full
decide on
thickness
patient
retinal
management.
break.
I continued and
So I wanted to put up this
they-
quote
So this is one important slide which is showing an
the art
important
of
marker
medicine
in chronic
consists of amusing the
central serous.
patient
If you
while
notice
nature
this area
cures
which
the
is
disease.
under the
This is what
neurosensory
it is.
retina within the vessel wall,
This is
usually seen in
progressive
chronic
elongation
CSR.
of the
And
photoreceptor outer segment.
after 2 months of the
This
same patient,
place and then
another
here,
finding which you notice here is hyperreflective dots,
We've
which is
done,
longer doesn't mean you're doing well.
you
It
know, so
means
many
it's getting
technologies have
hyperreflective
come up
dots have come
at
down
the
and the
right
SRF
time,
has
right?
come down. So that's another
Nothing
marker for us to note in case
In
of chronic
conclusion, what I'd like to say is because we have multimodal
patient.
imaging and we have
This is one rare case which they have described where
best thing
you
is
have
to put
so
all
many
these
other
images together.
high pressure
technologies have
PED
come up
which has
like
ICG, OCT. It has not only ruptured the retinal
in the
pigment
diagnosis
epithelium,
and
but also
also
gone through the retina and
help
towards
us
the
in
patient
doing
and decide on patient management.
I continued
So I want to put up this quote. This is
using
one important
these
slide which is showing an important
diagrams
medicine consists of amusing the patient. If you notice this area which is under the neurosensory retina within the vessel wall,
This is
usually seen in
we were diagnosed with PCDs that time also, but we didn't have any treatment. We knew that we are dealing with CNS and 99 reports have come up. 2000 we had treatment. So for 6 years we did not have
for us to note in case of conclusion. What I'd like to say is because we have
that was the time
multimodal
perhaps
patient
where
imaging
we
and we have
learned
this is one rare case which
a lot of
described
ICGs
where
and we
you
were
have to put
seeing
all these images together.
has a potential for
ICT all has been that all over the India and also ICT I have never found scientific everything like diabetes, but I've had experience of endoneurology, high marks, I've had lines of even I'm sure they must have some light systemic side effects of coming over or moving on to OCT and geography. So the rationale is that there is a non-mobile tissue which has a different as compared to the moving erythrocytes, and they cause the back scattering of hazard potentials. So there's gives us use 3D reconstruction of blood vessels, and we can look at these transverse cross-sectional OCT scans. Comparing fluorescein with OCTA, we know that it is non-invasive, there is no dye used, high resolution, more affected by motion. So if the patient is uncooperative and the patient moves the eye a lot, then we do not tend to get a very good scan, so we cannot do the segmentation at excellent levels, and then we miss out on a lot of things. So now we get images which could be superficial retina, deep retina, outer retina, and choroid at 4 different levels. Never before have we seen cut the retina into 4 segments and seen the retina carefully at all 4 levels. So it takes very little time, and we can do it in all our patients. We want to know about CNVM as regards its location, morphology, and response to treatment. So in the outer retina, and also the Brooks membrane, there is no signal because there are no vessels. But whenever you see a vessel in the outer 2 layers of OCT angiography, there has to be choroidal vessels there. So this forms the basis of our diagnosing CNVM We can see neovascularization, we can see dilated vessels, we can see non-perfusion, and all of them exist in choroidal vascular disease. Let's compare the two of a large mature fibrovascular scar. This is a simple fluorescein angiography, and you can see that how it leaks. So this is the Brooks membrane. It gives us a exact, what is happening to all these vessels. But the only disadvantage here in OCTA is that it is not leaking, so we are not sure if it is an active vessel or it is a quiescent vessel. So we have to really make out on our own that what are we getting. If you have a CNV like this, and you can make out the extent of CNVM, this is what OCT angiography helps us. Let's look at another one. This is FFA of the same patient, ICTA of the same patient, and you view. This is how it tells us. So let's give an example. This is before treatment of CNVM. Before treatment. This is 24 hours after treatment, and this is 7 days after treatment. This is how it is. 30 days, it's again. This is what we see with anti-VEGF every day. That after 1 month it comes up again. You give another injection, it goes down, then comes up again after another 1 month. So after this, it's come back, not perhaps to the original level, but it's come back. So you give another injection. So this is after 24 hours, it's again gone down. 10 days post-treatment, it's almost disappeared. And then 30 days after treatment, it's again come up. So this is how we have not been doing ICT in all our follow-up patients, and we've not really known how this CNVM behaves. Now with OCT angiography, it is possible to look at these patients apart from doing light scans. We can do OCT angiography, all these patients, and see how these CNVMs are behaving. This is a myopic CNVM, FFA, ICTA, and this is how it is in OCT angiography, a light scan. Different patterns that are seen in OCT angiography are, we could have a Medusa pattern, a C-fan pattern, indistinct network, or a pruned vascular tree. And this is how it is doing, whether the lesion that we are looking at is active or it's quiescent. A typical lacy wheel shape is active as compared to long filamentous linear vessels. With numerous tiny capillaries, they are active. smaller the vessels, active they are. And sometimes, in these kind of vessels, or, at the edge, there are tiny lacy capillaries. So that means it's still growing and it is still active, but at the margins. So you can have widely anastomosed network. More the anastomosis, more the loops between the vessels, more activities. And in the peripheral arcade, if in the margins you have all those small lacy vessels, that means there is activity. And most of the time, you see this perilesional hypo-intense halo. So this is a halo around the lesion, it's active. So these are the kind of things which tell us in OCT angiography whether we are dealing with the active lesion. But the most important is when you are, I'm sorry to take more. So you can have, when you are dealing with this kind of disease and you are cutting your sections in the deep retina sections or in the outer retina sections, if you have edema in the neurosensory retina, that means that shows the activity. So that is the most important sign that what you're dealing with is active. These are the 4 levels we see. This is the superficial. We cut the retina at this level, superficial capillary plexus. Then we cut the retina at this level. Then we have outer retina and the choriocapillary. So these 4 sections we have. This is the superficial, the deep retina section. This is the outer retina and the choriocapillary. So let's start deep retina sections. What I have seen. If you have the edema in the deep retina layer, and now, this is the second one, and most important, this is the outer retina, and you can see a very nice bunch of these are the 4 levels polypoids here. This is the choriocapillary layer, superficial capillary plexus. Then we cut the retina at this level, then we have these outer retina and you can see all these polyps here. Sections is the second phase. This is the superficial and this is the outer retina section. This is the outer retina and the choriocapillaris layer. This is the choriocapillaris layer and you can't miss these. Another one, there's a huge PED which is involving, and these are the bunch of polyps that we can see. The advantage of seeing these polyps is that you can then, have your treatment around that area while you're doing your PDT. So this is the outer retina. This is the deep retina, and even in the deep retina, once the polyps are huge, they are even visible in the deep retina. Outer, and this one is the choriocapillaris layer. Another patient. Look at these bunch of polyps with the branching networks. PED, and these are the polyps. So this is the area where you have polyps in this patient. Polyps could be anywhere. So you just have to know where they are. So this is another patient where just in the center of PED, there are polyps. So you know whether to treat PED in these patients, whether to focus your laser in PDT, where to focus and where to give more energy. This is where our polyps are. In all these patients, I have not, after spending so many years, I've been doing this since last 2 years now, and I can't remember any patient where I was suspecting and looking for polyps and have missed them. So this is where our polyps are. Another patient, lot of polyps in the center of the PED. So you can move this line above and below and look at the line scan accordingly and then make out where it is. So let's now move on to CSR, central serous retinopathy. This is a patient of a chronic CSR, line scan. You can see the thin retina. Actually in CSR, line scan perhaps is, as far as I feel, is more important as compared to looking at all these layers, except yes, while you move this line, you can know the extent, the exact extent of your CSR, and you can mark that area and accordingly treat the patient with PDT. So, and also you can know the extent by various other modalities, by autofluorescence and all. And in the choriocapillaris layer, you can see that there is pachychoroid. And this is after PDT. This is how it seems. Now, another patient since 4 years, chronic CSR. You can look at these ragged margins, fuzzy edge
chronic
of the
CSR line scan.
retina.
You can see the
This
thin
is how
retina.
it seemed in the
Actually,
superficial
in
layer,
CSR,
and then you
line
go to the
scan
deep layer.
perhaps
Deep
is,
layer is
as
usually,
far
if
as
it's
I
a
feel,
chronic
is more
CSR,
important
it
as
usually
compared
gets
to looking
dark
at all these
areas.
layers,
It has
except
dark
yes,
areas.
while you move this
and
line, you can know the extent,
this is the outer retina.
the exact extent of your CSR,
And
this is
then comes the choriocapillaris, and you can see these bigger vessels,
and also
choroid or
you can know the
pachychoroid,
extent by
and this
various
is how it
other
seemed after
modalities
PDT.
by
I've
autofluorescence
seen a lot
and
of
all.
patients, and
in
PDT
the
never
choriocapillaris
fails
layer,
in
you can
chronic
see that
CSR.
and,
I have
there
never
is
even
some
seen a
pachychoroid,
single patient
and
which
this
has
is after
not
PDT.
responded
This
to
is
chronic
how it
CSR.
is. Now
It's a
move on to
great
years
modality
chronic
to be
CSR.
used for this
You can look at
indication
these
where the
ragged
patient either has
patient
bilateral.
margins,
This
fuzzy
patient
edge.
had
Chronic
bilateral
CSR line scan, you can see that this is
CSR, and if the patient has already thinned out the retina in one eye and the other eye is already very scared, so you can do this.
It usually gets
So you have these dark areas there in the outer retina.
This is the outer retina. You can know the extent. This is the outer retina.
And this is the choriocapillaris layer. But the pachychoroid is more visible in the line scan. So I have two more patients where I had done, but let's move over to CNVM OCT. Now this is 60-year-old female. These are the mature vessels, while in the center now she is developing the CNVM has migrated in the center. And then you can see that the patient has edema in this area, and when you have edema, this is the CNVM, and it has migrated down in the center. Now when you have these mature vessels, even after doing your treatment, I have just given one injection of Eccentric, and in the center we did the OCT scan again, and in the center the vessels had disappeared, but these mature more visible remain, and they are the ones that might again extend over to the center and the patient. So this is how our patient when the macular area is better. This is another patient with CNVM in the center. These are the four different sections, and this is the second one, that is the deep retina, the hypochondrial and these other vessels in the outer retina. So in the last CNVM, we are mainly looking at the outer retina and the choriocapillaris. So in post-purulent sensor, the 70-year-old female with CNVM, line scan of and there was a sign of edema, but we started trophy also. So this is the outer retina, and the choriocapillaris. So after our patient is definitely by those
clips on